All right. I think we're up. We're running. It's 5:01 Eastern time. So we got a little late start, too much goofing around. Sorry about that for everybody that's waiting. Happy Thursday. We're here. We got Dr. Kipros here.
Hello, hello.
Closing out the day. And there's Dr. Tinwaldy.
Hello.
Double shot today. We were going to see if she could do a creepy entrance in the background. I don't know that was creepy, but
I'll resume it.
yeah. Try another one. Try another.
There she
that's
is.
good. That's good. Very nice. All right. So what do we have today?
Oh, I'm excited to talk about a case today. This patient's fairly recently been in with us, but she came in initially, did some treatment, went home, did a ton of work at home, came back, did some more treatment. She had some pretty big goals of what she wanted to get back to in her life. So she is a 27-year-old female. When she came with that to us, her chief complaints were around experiencing tachycardia, but then she would also notice that she would experience periods of bradycardia as well. So she's like, my heart will go so fast, but then I'll also notice it's going too slow. So it doesn't necessarily to respond to what I'm doing appropriately. She was also getting palpitations. So not only was the heart rate not being what she wanted, but also the rhythm. She would notice she gets palpitations when she would move around or when she would try to exercise, do things like that. She also experienced feelings of pre-syncope, so never actually passing out or losing consciousness, but feeling that preempt of that coming on. Blurred vision, which would get worse with movement, both of her moving her body, moving her surroundings moving. So driving was really hard. Lots of nausea and motion sickness. Using the computer was really hard. She was down to basically not being able to tolerate any computer time, which was difficult because her job required her to use a computer. And then she also talked about having a lot of headaches and body pain and soreness, extreme fatigue, especially after trying to exercise. And then also she mentioned this increase in urinary frequency where she was like, I just have to use the bathroom all of the time. And I'm a 27-year-old. I should be able to space this out a little bit more. So she did come to us with a history of having several concussions from playing sports, and then also a couple of viruses and illnesses that she'd experienced. And these symptoms seem to have just been gradually getting worse over time as she got another head injury and got sick again, and just things were accumulating over time. So for her, she came with like, I'd really love to be able to like drive for more than 5 minutes at a time. I need to be able to use the computer again to go back to work. And I want to be able to exercise because I enjoy doing it. And it's really hard right now. So she came in, we started with our examination. What we noticed out of the bat when we did that red saturation test, which we've talked about, I think, on here before, you're looking at a red color and you cover. So in her neutral position, she would get darker from her right eye, but then in any head position that you put her in, it would switch and become darker from the other eye. We also looked at her reflexes. So all of the reflexes down in her ankles, at her knee, in her arms were too reflexic. So we would get too much of a response when we touched or tapped onto those. And she also had what's called a positive scapulohumeral reflex. So a reflex when you tap the top of the shoulder up here, where you should see nothing happen, but for her, her whole arm would move like this. We also saw that she would get, when we brought her head into a down position, she would get all this tingling that came in her head, in her face, and in her hands, which is called a positive Lay-Hermits test with that position. And she could get that if she sat up and tucked her head down, as well as if she laid down and tucked her head down. We also saw that in that same position that created all the tingling, if you tapped those reflexes that were already a little bit too high, they would become even more. So a reflex that was already hyperreflexic in that position of her head would come even more hyperreflexic. When we looked at her sensation, she was able to perceive her sensation everywhere. So we looked at pinwheel, we looked at light touch, we looked at vibration, we looked at cold. All of that she could feel, and it was equal in her body. But then when we went in and did something that's called graphesthesia, where we draw a letter or a number on your body and you have to interpret it, she could feel that the letter was being drawn there, but she couldn't identify the letter or the number on her feet or on her hands. Mm-hmm. We also looked at how well she was able to move her head around, and she had really restricted range of motion through her cervical and her thoracic spine, so through her head, through her upper back. And with her moving through those, she would get that feeling of blurred vision, lightheadedness, nausea just from moving her head around. And then she would also get it when you just moved her eyes around. So if you had her track back and forth, track my finger back and forth, just follow it, track my finger up and down. What we saw looking at it is that her eyes would jump ahead of the target and pull back, ahead of the target and pull back. And she felt like that reproduced the motion sickness that she feels in the car when she tries to use the computer or when she has to like be in busy places. So looking, we put the goggles on, we put the VOG goggles on, and we saw the same thing that we saw bedside tracked on that VOG. So in a sec, I'll pull a picture up of what we see when the goggles are able to map those eye movements, of when, especially in her tracking and her pursuits, her eyes are unable to stay on the target and she gets those backup movements, too far and then back up, too far and then back up, when she's moving side to side and when she's moving up and down. Now, we talk a lot about the autonomic testing as well. So for her, what we saw with the autonomic testing is that when we took her from that laying down to upright position, she was actually able to maintain the perfusion in her head, or the blood flow to her head, in a normal range for her. So we weren't looking necessarily at not being able to put blood or not being able to appropriately perfuse her head, but we did see that with her breathing and with her change of positions, her heart rate and blood pressure response didn't follow the exact pattern that we would want it to. So even though she could put blood in her head, the reflexes that governed the heart rate and the blood pressure response weren't as finely calibrated as we would want them to see. So I'm going to pull up the image here. So when we look at the VOG or the videoocleography, we can see what the eyes are doing. So we get a video of what the eyes are doing that we can look at, and we also get a graph, or basically a map of what the eyes are doing. So when we look at this one here, this is, you can see at the top here, it's her smooth pursuit, which is basically her ability to track her eyes back and forth along a moving target. Now the target's in the dark, there's nothing else going on. It's about 30 seconds. The black line is the target, and then the blue and the red is her eyes. So all of these blue jumps are where her eyes go. You can see it go past the target, jump back, past the target, jump back, past the target, jump back. And then you can see it when she comes down, when the curve is coming down to the left, and when she goes up. And the same, if we look at it here, a little bit more deviation from the target here in this vertical plane.
Mm-hmm. And it's worth noting for everybody that's not used to looking at these, the first graph was horizontal, so that's tracking left and right. And so even though that graph, it always looks like the up and down wave, it's kind of like when the line is going up, that's the eyes both going to the right. And as it's going down, that's both eyes going to the left. And what should happen is it should just look like a tracing. So where you see those two lines, it should just be two lines on top of each other. And that just signifies that your eyes are able to stay mapped right on the target, which is not very hard. It's a very simple task that most people are able to do. So when we see them show up like this, where it's so difficult, then that is really helpful for us, because it helps to point to then, okay, then you ask the question, well, what part of the brain is responsible for being able to make sure that my eyes can see a target and then track it. And turns out it's different if we do it with both eyes going to the right than it is if it's both eyes going to the left, which is a little different if they're going up versus down. So it helps us to be able to calibrate where in those areas of the brain something's going on. And then we can then triangulate that with all of the other exam findings to be able to understand how those pathways are connected. So what Dr. Kipros is showing here is we have both the horizontal and the vertical pursuits, just simply keeping your eyes on the target, have a profound loss in the ability to do that.
Yeah.
Cool. Keep going.
Cool. So when we took the exam findings from this patient, we were able to see that there is this cervical component, right? So we were finding exam findings that were related to reflexes, especially reflexes through her neck and the way information travels through her spinal cord. But then we can also see that there's these reflexive systems in the way her eyes move, and there's the reflexes in the way her heart beats and how she regulates her blood pressure that's not being executed as well as we need it to. So if we start to bring that all back, we look at, well, what is the thing that coordinates the eyes, and what is the thing that coordinates the autonomic responses, and what is the thing that coordinates the way our neck move? Well, all that comes back to the brain. So when we start working with her, we started to look at, can we use some manual therapies? Can we use some proprioceptive therapies? Can we move the neck and train the brain to move the neck in a way that's different so it doesn't cause us to have these signs that are associated with cord compression or cord interruption first? So that's where we started with her. We started to passively move her head and allow her brain to get information differently about where she's putting her head in space so that she doesn't get those signs. And once we did that and we could orient her head there, we started to move towards, okay, can we now give her exercises that target her eyes moving to targets and holding? So we then added in some where she would move her eyes to a target and hold, move her eyes to a target and hold. And then we brought in, started using whole body rotation. We added some complex movements in on top of that. And then we gave her some exercises that allows her to build a little bit of stability and control around those muscles that are needed to hold her head in that position.
Yeah. And I think this audience gets it pretty well. We can even talk a little bit more depth about those pathways because I think it helps to understand it. So when you think about these pathways of understanding where things are in space, you kind of got two drivers. We think about things in terms of things that are reflexive, things that we don't necessarily have to think about and our body's able to do them without our conscious input per se. But then we have other things that we kind of have to we've got to focus on and engage in the process. And so by looking at changes in graphesthesia and changes the way we move our eyes, the way we control head and neck movement, it's kind of like we think about the development of kids, right? So obviously when you're born, you don't just come out ready to play soccer, right? You've got to first learn how to hold your head up and then sit up without tipping over and then be able to roll over, all the things out of order there. But we think about brain development the same way. So the way that we're structuring this is we're starting with the portions of the pathways in the brain that are more medial. So if you think about the way a tree grows, it starts that nice little small seedling, and then it grows ring by ring by ring by ring by ring over the course of time. For those of you guys that are asking about the Ivabradine discussion, it's probably your first time here. We share a case study first, and then we'll talk about that. So hold the horses, or you can catch the repeat. But so someone's brain, our brain when we're developing, starts off as just a nodal cord. So it's one line of cells, and then it grows like those tree rings. And so if you think about the way the complexity of our system develops, it develops by moving from in to out, down to up, right? So the pathways that tend to be more midline, they tend to be older and they're more foundational. So when we think about, we have all the way up to these volitional things that we're trying to do with our eyes and manage the way our eyes and our head move, and then that turns into riding in a car or working on the computer. we have to start from the portions of the portions of that information transfer that are the oldest, the more midline, because that then is what the next layer is built on, and then the next layer is built on, the next layer is built on. So as we're moving through these treatment protocols, the idea is we're building in a skill at a time, and we're layering them on top of each other based on these homologous columns. And so that's what Dr. Kipros is describing, is how do we start with first just like, where's my head? Where's my head is an awesome skill to have, but I have to know where that is before I can then coordinate my balance. And then my autonomic reflexes are tied to that. And then the way I move my eyes and control my spine are tied to that. And then we can build them on top of each other, going from those reflexive things to the more complicated volitional things. And that's what we have here. You want to show the next part?
I do, because that's the exciting. So we, like I said, she did a whole bunch of work. We gave her some stuff to do at home. She came back. We looked at retesting these. And here is when we were able, so these first ones we were done in April. And then we retested here in June. And these are the way, so this is her horizontal pursuit here. Right? So
look at that top graph.
Right here.
You can see, yeah.
Yep. So this is more what it should look like, right? Her eyes should track directly on top of that target, just like this. So that's in her horizontal plane. And then here is in her vertical plane.
Beautiful. And the thing I like about this is we can use these as measurements that are, they're tertiary, meaning what we want to look for many times is we don't want to just say like, oh, you're really bad at tracking things. So what we're going to do is we're going to sit down and do a bunch of tracking things. Right. What we want to do is instead say, what's tied to that pathway? And if we do these other types of stimuli over here that don't use that pathway, can it affect the processing in this other area? And that helps us to be able to know the impact that it has on that portion of the brain, that pathway. Yeah. And then it also tells us how well that plasticity develops over time, how permanent it becomes.
Yeah. So for this patient, she actually never did any therapy that was just her tracking her eyes back and forth. All the therapies targeted that area of her brain to aim to get it better, but that was not one of the therapies that she ever did. So what's cool for this is if she's looking at something like being able to use her eyes, being able to be in space, being able to track things, seeing an improvement like this is really important. And what it led us to do for her is it gave her the confidence that she was able to like gradually start adding some of those tasks back into her life. And why I think this is important is because we see these things and we can see how much better it is. But then we can also recognize that like being able to track your eyes in those goggles at a single target for 30 seconds is so much better. But that's a lower level of demand than her going out and having to be in a busy place using a computer, driving, doing all those things. But it has to be solid at level 1 before it can be solid at level 10. So this gave her and us the confidence that she's like, I'm going to start building up my computer time. I'm going to start going for 5-minute drives and expanding that out. And she's been able to do that since leaving the clinic, which is super exciting. She started less hours at work, but is now building out to more hours as her tolerance and strength improves. But it was really cool to be able to see those changes and then allow her to have the confidence to start building those things back into her life.
Yeah, it's very much a workout system. So part of the theme tonight is we're going to talk about a medication. We're not medical doctors. You don't have to listen to us. We're not prescribing them, nothing like that. But I know that I am guilty in my life of being like wanting things to be a little easy, right? Sometimes you just want to have it be just the easy way to do something, not always the hard way. But when we look at these types of problems, it turns out that they respond best when they're under challenge, right? So the way our body tends to respond is when it is given a stimulus that is above its current capacity level. I didn't make it that way. That's just the way it worked, right? So we grow things by challenging them. So by doing that, by being able to structure those challenges in a way that we constantly make your brain have to get better at these tasks, it allows it to regain its capacity, which is super cool. But it takes a certain kind of person like this to be able to just do that day over day and get a little bit stronger each day. And so I wanted to take a moment and just say like how much I respect that, because it's not easy. You got to show up and do it every day. And she did, and it shows, and it'll have an impact on the rest of her life, which is amazing. Yeah. So it's pretty cool.
Yeah.
Very cool. Awesome. So thank you for sharing that. It's good to see she's doing so well.
Yeah, I'm very excited for her.
Back in the world. And the rest of us are going to talk about study that came out, this Ivabradine trial. We'll get to the bottom. And the thing about this is it's kind of like a developing saga. So this is going to turn into a bit of like a soap opera, because right now we just have the presentation that came out of like a meeting. So like it's a presentation, not the paper yet, but we're going to talk about all that, and we'll rock and roll. So thanks so much for sharing, Doc.
Yeah, of course.
Appreciate you. Awesome.
I can't wait to listen to the rest of it, but I'm gonna close the clinic down for the night, scoot home, and then we'll be back rocking and rolling tomorrow.
Sounds great. Okay. Thanks for doing it.
Of course. Have fun.
All right. See ya. Okay, guys. So for those of you new, we'd like to start off the live stream by just sharing some stories about what's going on in the clinic. Usually it's a case of some type and kind of what's been going on, how we're doing, just so people can get a sense of what it is that we're up to, and maybe even see themselves in other people to some degree. So that's why we do that. This one, usually they're tied together a little bit. This one's not, because we just wanted to share this one. We didn't have an Ivabradine case pulled up offhand, and we just went with it. So there you go. But that's what we're going to talk about today. And it's kind of, it's a topic that we can really get in the weeds on, but I'm going to try to keep it high level and just make it useful for you guys so that it makes sense, it's functional, and we can learn in a way that's not overwhelming, and that we can take it and do something with it. So it kind of starts with this medication trial. And I actually think it's a really good trial. First things first is I really, really, really want to shout out the authors that are involved in this study and the others, because being an author on these studies is actually not easy. We were talking about this earlier. This is the group. Let me see if I can pull up their names here. This one. So you can see these are the principals. Love them. Wonderful. Thanks for doing it. But it is, so when you first start kind of getting into the field, you think about like research is like term paper or something that you do, and then you just kind of gut it out, and there it is, and off you go. But it's a ton of work. It takes a ton of resources. It takes a lot of people being involved with it. We're trying to be very specific about how you answer a question. It's very hard to do that, especially with patients. The really hard thing about these types of studies with patients is that you have to maintain a thing called equipoise, which is basically like you can't hurt anybody. So if you know the outcomes are not going well for people, technically you got to stop doing the studies. So you have to build the studies in a way where you can't just like fully neglect people and be able to like measure all the variables. So it's actually really hard to run randomized controlled trials. So you end up doing them in very tight ranges like this one is done, but it's useful. So I want to say a big thank you to them for doing that. It's a lot of work. So that's number one. Number two, remember, I'm not an MD. I don't prescribe medications. We work with teams of other people that help us to be able to understand that process for people, how to tailor it to them in their journey. That's the way we do it. The reason we're talking about it is because there's such an overlap, and it's worth understanding. So all we're going to do is just talk about a thing that other people have talked about, and we'll see if that helps people understand a little bit more what's going on. So we'll start with the study. Let's start first of all with what Ivabradine is. Let's start there. So Ivabradine is, I'm going to unshare this for a second. It's a medication that's used, it's the evolution of it being used in POTS cases is predominantly from its use and its on-label source, which is it helps with heart failure. Heart failure meaning like it can't pump hard enough. So what this particular medication does is it acts on this part of your heart called the SA node. It's where the electrical impulses come in from the back of your heart, which is the cardiac plexus, and it talks to the kind of the top chamber and it sets the electrical rhythm for what's going to happen for the whole heart. What's unique about this particular drug is that it is able to slow that down without dropping the cardiac output, without changing the blood pressure. So one of the problems with things like, propanolol, for example, or beta blockers as a group, is that they block the whole beta-adrenergic system. So they can bring your heart rate down, but then they also tend to bring your blood pressure down, which is not ideal. What Ivabradine does is it slows the heart rate down, but it also maintains the contractility of the heart. So it still beats hard enough, so it still pumps the blood out. So basically it takes the reflex of the normal reflex where if you're decreasing return, and we're going to start beating faster to try to compensate that, it shuts that reflex off and it says we're going to slow down, we're going to let the heart fill a little bit more and then try to get more out of each contraction. And that's kind of like the general sentiment around what Ivabradine is for. So you can see the use case if you're looking at POTS from a heart rate perspective, which hopefully, if this is your first time, excused, but we tend not to look at it from a heart rate perspective, which is unique. We look at the heart rate as a consequence of whatever the actual problem is. And that can be different in many different people. And we see that as a journey that you're actually trying to solve for in POTS. The heart rate is compensatory. It's actually not that the heart rate isn't failing. The heart rate is actually like in overdrive. And because it's in overdrive, we know it's in overdrive as a way to compensate for something else that's not keeping up the way it should be. Okay? So when we look at this medication, the idea was, well, maybe by just dropping the heart rate down, we can knock down some of these symptoms, and that seems reasonable. And so what's interesting is the author, there's a lead up here, but we can't be here all night. But basically, there was an author that came around in 2021, Dr. Taub, and she applied using Ivabradine with hyperadrenergic POTS patients. And the way that they defined that was just people where they measured elevated levels of norepinephrine. Their average, I think, was around like 530s or something like that. I'm going off the top of my head. But norepinephrine, to be very important here, is when we hear epinephrine or adrenaline, we think about like adrenaline in the movies where it just amps you up and you rocking and rolling. What we're talking about here is norepinephrine or noradrenaline. And that nor part, you can think of that N as like it's for nerves. So it is the signal, it is the neurotransmitter that jumps from one sympathetic nerve to the next sympathetic nerve in the chain to end up at whatever its job is to do, right? So if we have increases in norepinephrine, independent of like a tumor, what it's telling us is that there is a broken feedback loop. So that nerve just keeps firing and it doesn't know if it's doing its right job or not. So the brain isn't able to interpret if it's doing the job. So it keeps firing at a higher and higher rate. And it ends up creating an increase in the amount of norepinephrine at the nerve cleft. Okay. And that tends to come with a different set of symptoms because it just keeps jacking that norepinephrine into the nerve. So it's like, it just keeps stimulating it over and over and over again. And so people will tend to have more symptoms that are related to things like heart palpitations. They tend to feel more anxious. They tend to feel more akathisia, where you feel like kind of vibrating, like your motor's running. More vigilant, more anxious, like that type of a presentation. And so what they found in that study was a small study, but they were like, it seems like it seems like number one, when they give the Ivabradine for that particular subset of cases, it does tend to bring down the heart rate when you're standing up better than a placebo does. So, and then there was a correlate to that where some of the symptoms that people would experience, some of them would feel a little better, which is cool, right? So if you're white knuckling it through the day and you're taking some Ivabradine, takes the edge off, that was useful for people. Cool. So they take that away from that study. And then there's this recover trial that's going on. And that's kind of the basis of what we're going to talk about today. And that's where basically the NIH, COVID comes around, they're like, we got to figure out what the heck is going on here. So they get some super smart people to come check it out. And we end up with this kind of recover group, let's call it that. And super smart people, and they take, Taub is part of this group, so they take and they say, you know what, let's see. Turns out there's like 30 to 40% of people with post-COVID sequela that have this phenotype that looks just like POTS. And Peter Novak did a great job of ironing that out, did a lot of the objective testing looking at that. And they're looking at saying, okay, well, is there an application in the same way using Ivabradine? And so in this study, that's basically what they set out to do. So they went through and they have this developed system here. Well, I won't skip ahead just yet, where they're going to look at that relationship, but they look at it in an interesting way, where they're going to look at Ivabradine versus placebo, but they're also going to look at it in this matrix where they're also going to look at basically using coordinated care versus not coordinated care with the Ivabradine. And so what the coordinated care meant was they're going to have somebody give them a call once a week, remind them to do their salt, their socks, their compression garments, and increase water, and doing some basic PT recumbent biking, basically. But they just do that each week, and they make sure they kind of keep on it, and they follow up with them for 3 months. And the interesting part was they presented this, Dr. Taub presented this in March, and what they found was really interesting. And they did this study. It's the biggest one that's ever been done. They had 181 adults. It took 40 different centers around the country to get this done. So they worked at this. And they were randomly assigned to either get Ivabradine or placebo, and then whether or not they would get coordinated care or not. And what they found was the treatment with Ivabradine did reduce the heart rate compared to the placebo. So the mechanism of action, like what it was designed to do, it does do. It does decrease the heart rate. But what they also found was that didn't significantly improve the POTS symptoms in people that had long COVID. And so that part was the interesting part, and it's the part that intuitively we kind of understand, which is why it's very important. In saying, if we can ask ourselves a question of why is the heart rate high, then that will lead us down a whole new set of trying to understand what the reason is, right? But if instead we say heart rate's high, let's just drop it down and see what happens, then we would expect, if it is compensatory, that people won't necessarily feel better because all we've done is stolen their compensation. And that's kind of where this arrives, which is really, really useful. But what's interesting to me, though, is we do have some studies that show like portions of those symptoms get better. The two big ones tend to be the palpitations tend to feel better and the anxiety tends to come down, which is part of the feedback loop of tachycardia. So it's really interesting. So it's not to try to make it a binary of like it either helps everyone or it helps no one. That's not the plan. Just realized that I didn't turn on our TikTok group. They're going to join us in the middle of the show. Whoops. Okay. Got it. Okay. So the TikTok crowd's missing a little bit of the show, but just to pick it up. So if we have the Ivabradine study, if we're applying Ivabradine We don't have to look at it as this like binary thing, either helps everybody or helps nobody. What it helps us better understand is the role that heart rate plays in POTS. And it turns out just by decreasing heart rate, that may or may not have an effect on any symptoms. In the ones it does have, great, anxiety, cool, has a better effect on sensation of palpitations. That's pretty cool, takes the edge down. But it also makes sense that for a lot of people, if that core factor is that my heart rate is actually the thing that is keeping me running, then that's probably not going to solve for that problem. And that's basically what they wanted to get out here. And they talked about this prior to the actual publication of the paper, which is also really interesting. One of the things that I want to point out is that there are portions of this that I'm kind of like excited to hear what they actually publish in the study. So if we look, because if we go to the study design, well, let me see here. Let's go here. And so there's this, you guys can find this. There's in the American College of Cardiology, they did a little podcast exactly 1 month ago. And Pam Taub was interviewed in this. And we went and got the transcript, and Chris was kind enough to pull this out for us here. And there's some interesting things here because they did, like I said, they did that pre-trial 22 patients, and they did see that some people noticed some things that felt a little bit better if they were these high epinephrine phenotypes. And that makes a lot of sense because in this phenotype where norepinephrine is high, then bringing down that heart rate takes off some of the load. It's already telling you these things are going too much. So when we look at things that aren't working in the body, if things aren't working as well, we usually get a detriment in performance. It's very rare that we get sick and we're like, we are now way better at life, right? So as our body becomes less efficient, our outcomes tend to be less effective. And then we see the compensations that come in for that. That's a really important part of this. So when we see these higher norepinephrine levels, we see this high heart rate, these are all signals that this system is working too hard. So by taking out certain portions of that, we see that the compensation then has its own set of symptoms that come from that. So if we dampen the compensation, we dampen down those secondary symptoms. Does that make sense? I'll slow down here. I can't see the comments, but that part is kind of important. Okay. So that's really insightful. And what's really cool to me is Dr. Taub is the one that did this first study, the 22 patient study, and was like, oh, it seems to help these norepinephrine folks. But then she's also the one that rips around right here and is like, hey, here's the deal. It looks like this will bring the heart rate down, but in this study, when we're looking at these orthostatic intolerance questionnaires or orthostatic hypotension questionnaires, we'll get to that in a second, it doesn't seem to be making a huge difference in like their quality of life. So should we be looking at heart rate as the main endpoint when we are measuring for these cases? If you've been following us for any period of time, then you know that we feel like it is not the right endpoint. It is the compensatory endpoint. And that seems to be a lot of where they're at here. And I thought that Chris actually highlighted this for me, and I thought it was really good. So she runs a cardiac rehab facility. And so people with myocardial infarctions, if you give them beta blockers and statins, it doesn't make them feel better. It's when they engage in a structured program like cardiac rehab and they really improve their functional status. We talk about that in terms of capacity. That's when their quality of life gets better. And I think POTS patients clinically, I've never hand out a medicine without telling them about the lifestyle strategies. And that's what I've always seen in taking care of these POTS patients in my career. And so I would echo that, where it's like we just talked about in this last case. In order to rebuild systems in the body to gain function so that we can feel better doing life, we have to be able to challenge the body in a way that is useful for the body to get stronger. And so if we say, we can look at that in two ways. We can look at it as, what is our general strength? That's one way to look at it. how do we improve our general capacity in the world? We just do a lot of things that would mimic the things that we want to do in our life. But also, if we've been injured in some way, we want to focus specifically on that injury and where it affects in the body. And if we do that, I actually find there's a huge upside to being able to target specifically, because we're using a way smaller amount of energy and we're focusing it in the bottlenecked area, the area that is limiting other capacity from being achieved. And so that's basically where we're at here. She's also highlighting, this is kind of the other part of it, is that the specificity of the exercise really matters. And that goes, even beyond what they applied here, and into thinking about neurological pathways, functional pathways, even more so than just looking at overall fitness. And I think a lot of you have experienced that, where by just trying to get more fit, sometimes that can be helpful, but sometimes it also kind of like grates the gears against, like, you overshoot your capacity and then you just kind of end up stuck and tired, rather than focusing on where the bottleneck is and working through that. But one of the things that I am excited to look at, hopefully you guys will nerd out with me later, is so they're saying this orthostatic hypotension questionnaire is the primary measure that they're talking about right now. And if you look at this, they're using multiple different assessments. Number one, so these are all assessments that are like patient filling in the form, right? So the form looks like this, if you guys can see it. It's basically a checkbox. It's like 1 out of 5, lightheadedness, dizziness, fainting, blackout, imbalance, right? And so we have to do them, totally. But also, it's just such a lame way to try to understand an individual person. But I get it, like that's where we have to start from. But so that's the one we're mainly using here, and it does tend to be highly correlated, you can see here, with people that have particularly post-COVID types of tachycardia POTS. And so that's why they're using this one. And they're also adding in the Compass 31, the Malmo, and the VOS, et cetera. And then some of these other, these are more objective tests. But just trying to get a flavor for what's going on with people and seeing how their symptoms are doing. My hope is that they publish about kind of a little bit more depth of how all these different questionnaires pan out to the best that we can, which I think would really be useful. And then I'm also very interested in their autonomic function tests at the sites that can do it. It seems like they don't all do this. This is probably specific to Novak's group, where they measure the same tests that we do. And I would like to see how that correlates to what we see subjectively. Because I think, this is a little soapbox moment, so I apologize. But I think one of the things we have to be aware of is, in this moment, what we're doing is we're looking at a system where they're trying to treat the symptom versus trying to treat the compensation. And what is very interesting is what happens if we start to try to treat the underlying problem or the mechanism of failure. And if we think about it through that lens, does that get better? And so I really like this bend toward hoping to see what they find with their own autonomic testing in a way where we're not focused on just trying to alleviate the symptoms. We're trying to fix the problem and seeing if that affects the symptoms, which I think would be super, super, super cool. And so I know people are going to ask about, like, well, what about the different forms of POTS? We can see here that Ivabradine, for people that tend to have hyperadrenergic POTS, that's where Dr. Taub found, like, it seems like it helps a bit. It seems like it brings down some, it takes the edge off, which is cool. Other people find like it doesn't help with my particular thing. And I think that should be the point, is that trying to blanket say that everybody that has tachycardia when they stand up and normal blood pressure, we're going to try to match them to one medication that's going to solve all of it. Stating that there are lots of different ways that we can get that problem is kind of like doomed for failure. But if instead we are willing to look at the nuance and say, for these certain types of people, this can take the edge off. And maybe that taking the edge off is enough to where we can start to help them get stronger. And that is a very useful way to think about it. So hopefully, as you guys are continuing to move along in your journey, being able to think about the first order and the second order consequences of like, well, if I take this, what should I see? How could I measure that? How would I know if I'm getting better? How does that help me figure out what's going on underneath it? Like all those things become really useful, and maybe lead us continuing down the road of continuing to get more help for people. But again, at the end of the day, even this study says, turns out people that actually do lifestyle changes, try to build their capacity, they're the ones that tend to do the best, which is what we've been saying forever. We just tend to look at it in a way where we're trying to solve a very specific problem. So with that, I'm gonna leave it there. There's so much more to say, but it's worth saying, like, I'm not negative on medications. I know just with my licensure and just status, you might think against medications. We're not. Do I tend to have a bias toward I'm a little bit skeptical? Probably, but been that way my whole life. It's independent of my license. But if a tool is useful, we want to use it, but we want to understand what its limitations are and what its strong points are and figure out how do we help people get their lives back. So that's the main deal. So with that, I'll open up to some questions and we'll rock and roll. All right. We got our TikTok crew here. Hopefully you guys were able to catch some of it. I got you in late. Sorry about that. We'll take a few questions here. I'm gonna take them off our chat. Genia squared a couple away for me here. Okay, so the first one is, I have hyperadrenergic POTS. And so when people say this, though, we have to be, and this is not, I'm not saying this about you, but I'm just saying this in general. When we say we have it, it really has to be diagnosed with that norepinephrine study, which is a little bit tricky to get. Some people say I have symptoms that feel like hyperadrenergic POTS. And that can be really helpful to understand kind of where we are. Because blood pressure can be low, but not all the time, which that would make, if you think about it, one of the ways that you'll try to solve for low blood pressure is elevate your heart rate, right? One of the ways you'll try to solve for low blood pressure in your brain is to elevate your heart rate. Some people can have normal blood pressure in their body, low blood pressure in their brain. What's going to be the response generally, if we don't pass out, is we're going to try to push the heart rate up and change your breathing, okay? And so if I'm getting syncope symptoms, the first thing I want to know is, where am I measuring my blood pressure at? If I'm measuring it on my arm, but my symptoms are I feel like I'm going to pass out, we may also want to consider, should I measure the blood pressure in my head? And we don't measure it with a cuff. The way we know how to do it is to actually look at cerebral blood flow velocity, which is an extension of that blood pressure in the arm, and we look at that through transcranial Doppler ultrasound. That can be kind of the best way to understand. But then you can know, are those syncopal symptoms I'm feeling coming from a normal blood pressure with hypoperfusion in my brain? Or is it normal in my brain and I have to think about the problem differently? And if I know that, then I can start to solve it better, right? So if I know blood pressure in my head's going down, then I want to solve that problem. What's causing that? Neurological, structural, vascular, combination, what's up? Or if that's not the problem, maybe I need to look back through the metabolic consequences. Am I hypoglycemic? Do I got something going on with an infection? Like, what's up? So yeah, salt electrolytes aren't helping. They're not likely to if we have a normal blood pressure. So here's the tricky part. For most of you, blood pressure in your body is gonna be normal, but blood pressure in your head might not be. But most of the way that we manage blood pressure as far as circulation is that we manage it kind of carotids and down. So your body a lot of times is thinking like, I am crushing blood pressure right now, but I may not be able to fully sustain that in the brain. And when we do that, things like volume expansion, salt, water are going to be less useful because your body is trying to maintain a set point of a of a particular blood pressure. So by increasing the volume, your brain recognizes I don't really want my blood pressure to go up anymore. I'm going to keep it here, but that may not be enough to actually perfuse in the brain. Cool. Okay. Okay. That's a good one. Beth makes a nice point. Another problem with Ivabradine is it causes side effects with other medications. It does. Interestingly, during these trials, they had a really low dropout rate. The main medications we want to be careful with are just kind of again, not an MD, not medical advice, are the ones that are going to be more targeted neurologically because we're kind of overlapping these systems. So we just, contact your doctor, make sure that everybody knows all the meds you're on and we're thinking about it before trying any or changing any. Let's see here. Pale Spoonie asked a question that was slightly unrelated. What neurological processes are happening when I treat my neglect in my hand and then I immediately feel improvement on my POTS and vestibular issues? How do those signals travel? Well, this is the beauty of what we talk about with neglects all the time, is part of the core of being able to control motor outputs, how we move, is based on what we feel. So if we can't feel something, we can't move it. That happens volitionally. Those are the things we try to do. But it also happens with reflexes. So in other words, I have to have some sensory input in. It's got to be processed in my brain. And then that has to control a reflexogenic output. And so the vestibular system and the autonomic system, particularly around blood pressure, are both reflexes. And so if I'm not getting good processing of sensory signals coming in, I'm going to have errors in those reflexes on the downside. But by increasing the fidelity or the accuracy of those signals coming from the hand, it gives us a better reference frame to be able to coordinate where we are in space, which can then bleed into the vestibular system and the autonomic system on the motor side coming down. And we see this all the time. So I love that you are, and I hope that you continue to improve. That's fantastic. Okay. Travis wants to know. I'm also a little confused because my blood pressure and my heart rate go up when I stand. Is there always a root cause, and does post-COVID POTS actually go away? So there's always going to be something that causes it. Otherwise, it would just be random, which would be odd. So it would just be like your body choosing to do something, which is not likely. We want to think about, usually our body is going to be trying to help us be the most efficient body we can be at the lowest cost. So the most effective and the most efficient at the same time. So if there is an error in the system, your body's going to try to figure out how to solve it with the least amount of collateral damage possible. And that's what most of us are doing when we're in this scenario. So it happens to be that blood pressure and heart rate are going up. We want to look at arousal types of things. So like when those activities both go up together, we want to look at it. Is it the same caliber? Does it happen always the same way? There's lots of ways that we can look at blood pressure and heart rate to confirm that they are in sync. And if they are in sync, then we want to understand why is it that standing requires so much extra effort and output to be able to maintain functionality, or is this the problem? So that's a vague answer because there's so much you can test in there to really find out more detailed information where you can actually answer the next question, which is like, why is it doing that? And then the next question is like, what can I do to help make it stronger and fix it? Okay. I have POTS and OH. So that's really important. What will the specialist likely test for next? Also have numbness in the legs. Is that connected? So here's the deal. To get a POTS diagnosis, everyone, and this is not you, no shade, no criticism. To get a POTS diagnosis, it excludes orthostatic hypotension, and that's really important. So if I have orthostatic hypotension and I have tachycardia as well, the problem I have is still orthostatic hypotension. It's just telling us that we also have this compensation with heart rate that's trying to save the day. But if we have OH, there is no, like, we have to take POTS off the table. So in order to qualify to have a POTS diagnosis, one of the factors is you can't have OH, because if you got OH, that's what you have. And then you can also have compensatory tachycardia, which is fine. But the main problem here that we have to think about and solve for is, like, what's going on with his blood pressure? Why is it dropping? Let's solve for that. So that's probably a good place to start. Numbness in the legs, that, not advice, don't know enough about that, but can it be connected? Certainly. So I hope you're still early on in the journey, and we can find you some help and get you taken care of. Cool. I think it'd be good. I think you're a good candidate to get some help and get out of that. Okay. What V&G system do we use? We use the Neuroline system, formerly known as neurokinetics. Cam, are those high norepinephrine levels just an indicator that your body is choosing to compensate via revving up that system, not necessarily that norepinephrine has caused the issue? It's going to most likely be secondary. It's going to tell you that the reflex loop is not closing. The feedback loop isn't closing, so it just stays open, just keeps sending. It's like if you subscribe to something that comes every month, and then you realize, like, I don't want it anymore, but then you send an email to the wrong address to tell them to stop, they're going to keep sending it to you because they never got the signal that you don't want it anymore. And that's kind of a way to think about this. And those levels just keep climbing. They're not being recycled out of the synaptic cleft fast enough so that they can distribute and then cause some new fun secondary problems. I really don't, okay, so Olive UB, I really don't understand how the body can maintain blood pressure, but the brain isn't getting perfused. That's a great question. It's a really important one. So blood pressure in the body is a fundamentally different control system than blood pressure in the brain, which is actually kind of slick. If you think about it, the blood vessels in your body could expand as much as your skin can expand. But the blood vessels in your brain are limited by the size of your skull. And so any extra pressure starts to cause problems, and it's going to basically push on your brain, and it gives us symptoms, and we don't like that, right? So it's dangerous. So they have to be governed in two different ways. We have two different ways to deal with that. So blood pressure in the body is a core system, right? So if I don't have enough blood pressure from my heart going through my body, then I can't get it to my brain. I'm going to be hypoperfused. But we can also have scenarios where we do have adequate blood flow into the body, but the job of the vessels in the brain is to bias toward being able to slow blood flow down. Because we can always, like, crank open the nozzle and let the heart just, perfuse our brain. So what we're actually talking about is, in many cases, where we are either passively or actively reducing that blood flow that's coming into the brain. And I can give you three main ways to think about that. Number one is that there's a mechanical occlusion. So basically, something is compressing the arteries going into my head that makes a higher level of resistance and reduces blood flow to my brain. That can be one. When that happens, I get full artery, which means the baroreceptor in my neck is saying blood pressure is fantastic. So it thinks blood pressure is good and sustained. And then from there, I may not get blood flow into the brain. That can be one. Number two could be that the neurology of my blood vessels is miscalibrated, and it's actively restricting blood flow. It's constricting and preventing blood from entering my head, even though I have normal blood pressure in my body. This would be a signal problem, a neurology problem. We can have swelling of the vessels. This is a big one we see with inflammation from post-COVID, right? The group we just talked about, where if I have a vessel that's yay big, but it swells, the walls swell, it's going to swell on the outside and get thicker, but it's also going to swell on the inside so that the amount of throughput is going to go down. And so sometimes when you have that inflammatory cascade quickly, it can expose these problems that are already there. Another one to think about then would be looking at the venous side of the equation. So the blood trying to come out of the brain. So sometimes if we remember, the veins are not super strong. It's not like a hard wall. It's like a very flat, weak wall. So they're very easy to occlude. And if they get occluded and I can't drain the blood out of my head as well, it then becomes a math problem. So if I can't subtract it fast enough, I also then can't add it fast enough. And we start to get this kind of stagnant hypoxia where I can't get enough new blood flow into my brain because I can't drain it out fast enough. So all of these would be different examples of ways that I could have normal blood pressure in my body, but not have normal blood pressure in my brain. So hopefully that helps. Cool. And you could think about MCAS in a lot of ways as being similar to what we're seeing with the spillover in norepinephrine, where we may be getting a spillover in histamine response as well. And so that's really important too. Now, can we also see where immune-related problems can cause inflammatory loads for a period of time and then lead to sequelae that look like this as well? We also described that. And so you got to figure out which is which, what's starting the cascade, and then do I need to solve, this immune-related problem first, or is the immune-related problem secondary to something's going on with my neurology? And that gets tricky, but it's a very important question. Most people will find that because there are more providers that desire to look at the immune side of things, that often gets tackled first. And then people in that situation will find like, oh, that wasn't quite enough. And then they will just kind of default to coming to the neurology after that, when being able to look at how they interface together might be a useful strategy for a lot of people. Cool. Okay, where are we here? I'm gonna take a couple more, and I gotta get to bed because it's after midnight here, and I gotta be a doctor tomorrow. Travis, how do you know if you have hyperpods? Good question. So a lot of people have symptoms that describe hyperpods, and that's totally cool. It's useful to understand that, and then you do the testing after that. When we're really looking for it, what they're looking at is a norepinephrine test that's looking at supine versus standing, and we're seeing how much that acceleration of norepinephrine happens. It basically tells you how sensitive the system is to standing, and if we're getting an overreaction to standing, particularly within that subset of neurology. And that's really what you're looking for. I think a lot of people, in the desire to get better and to be able to have more focused diagnosis, will look at the symptoms and make a declaration based on the symptoms rather than the underlying pathology. The symptom part is important, but then that we want it to lead us to the right testing to be able to find the right answers. Cool. I think this is an important one. So, good morning. My daughter has been diagnosed with POTS, but is having seizure-like activity on an almost daily basis. I'm sorry to hear that. So now we're being told she has FND. That's a classic that's the thing that will happen. What are the main differences in the treatment between the two diagnoses? I think that's a really important question, and it's what you should be asking. And without knowing the case, and obviously I can't give advice on that because I don't know it, but what we typically see is that it's kind of the same thing that's causing this expression of what is being labeled FND and what is being labeled POTS. They're not necessarily different problem. It's just an expression of a problem that's happening that we describe in two different ways. So it's a limitation of language. And in many cases, we see people that have, especially younger kids that have hypoperfusion, will have these events where consciousness is affected because we're hypoperfusing the brain. But then we also may have other types of symptoms that are related to where we're hypoperfusing the brain. So if that's happening in the speech area, she may lose speech for that period of time. So even though she might kind of come back to, she then can't speak. Or sometimes we'll find people can't move a limb in that period after, or they can't move their eyes correctly, or they feel like they're spinning, or they, just depending on where in the brain we're getting hypoperfused, we may notice that there is a disruption in consciousness. We might notice that there are myoclonic activities. We might notice that there are tremor activities, and they may be associated with alterations in function. So if you look at it through that lens, then it might help to make more sense in terms of how to think about it, is in terms of solving the underlying part. But I wish you a ton of luck. I know, I mean, we've seen so many kids in that regard. I know that that's a tough thing for a family to go through. So we're wishing you all the help in the world, and good luck, and hopefully good outcomes soon. Cool. Okay. Okay, guys. I think it is time for me to go ahead and call it a night. These are great questions that are coming through. Sorry I couldn't get to them tonight, but next week, come back. We'll get to them. We'll keep answering them. A lot of the ones that I'm seeing, especially on TikTok, guys, are ones that get answered pretty consistently in our live streams. So if you need to know now, pop back another live stream or two, especially the Q&A ones, and see if that's useful for you. I think Ginia also, I don't think we have it on TikTok, but she posted the POTS roadmap. It's a free thing that we made. We'll give it out. No cost to you. We'll send you some emails. We give you some more education information that comes with it. That might be something that's really useful for you too, especially you know, when you're in the early stages of trying to figure things out and get organized. So if we didn't get all your questions answered tonight, that might be a resource that's useful for you. But until then, we'll keep making videos. Send stuff in. We'll keep making them. And we'll be back next week to do a live, 5 o'clock Eastern time. Hopefully we'll see you there. TikTok, we're trying to figure out how to merge you with everybody else, but hopefully we'll get that all done. So thanks so much for being here, guys, and we'll talk next week. See ya.